Welcome to this evening's webinar about applying the Brain and Mind Centre's youth model. As part of our case series, Liz and I, Associate Professor Liz Scott, and myself, Professor Ian Hickie, will discuss the further development of three cases that we highlighted during the original case series. What we demonstrate tonight is things don't always go as planned. What happens in certain issues, despite our best attempts to organise and arrange care in the first instance, what happens when, as we follow people up, things don't go quite where they wanted to go, or where we might have thought they would go. This is a really important kind of concept because actually, often we don't know what will happen. And personally, my biggest preoccupation is not how people get well, it's when people don't get well or they deteriorate. So that will be the focus of this evening. What are the choices we have, how we track people in real time, how cases might develop, and then how we might apply the Brain and Mind Centre model. So as with each of these seminars, we'll start by acknowledging the traditional owners of the lands on which we meet, which for us here in Sydney is the Gadigal people of the Eora Nation, and their learnings over many centuries of how to bring together the social and emotional well-being of people to maximise their mental health and in fact their mental well-being over long periods. And also to recognise those with lived experience of mental ill health and their contributions to the development of improved care and hopefully in the future, improved mental health systems. Go to the next slide. So just to recap, our Brain and Mind Centre model has two key elements. One is of highly personalised assessments, bringing together our multidimensional framework, clinical staging, and appreciation of pathophysiological pathways, and putting that within the context of a person's social and biological development. Taking those initial complex assessment processes and then combining them with measurement-based care, actually recording in real time the outcomes of care over a longer period so that we can make use of real-time monitoring, we assist that with technology, and we continue to look at the multidimensional outcomes. And that's an iterative process. And that's what we want to really highlight this evening, the way in which the initial assessments lead to tracking over time, and in this situation, when things don't go as planned, what we do next, so that we continually improve at the individual level the focus on clinical outcomes. Next slide. Just to recap, one of the really critical concepts for us is actually clinical staging, that we often early in the course don't necessarily decide exactly where people are, that we actually continue to track them, and particularly in the first month, particularly first 4 to 6 weeks, it may not be that clear where somebody is in terms of clinical stages. And that's something we're constantly looking to reassess during the early phases of care. And after the first 4 to 6 weeks, and certainly over the next 3 to 6 months, we are particularly sensitive to those who may deteriorate or progress from an earlier stage to a later stage and cause us to revisit our original assumptions. So while we rate down in the first instance, we're very vigilant over the particular next 3 to 6 months as to potential progression in clinical stage. Next slide. So there are 3 cases that we presented in the original series to illustrate people at different stages of our clinical staging models. Jane, who was a stage 1A, Anne, a stage 1B, and Simon, who is a particular stage 2 in this particular set of issues. So we're going to look at these 3 particular cases now in some particular focus, particularly in the first case with Jane, that she transitions from an earlier stage to a later stage of a follow-up. For Anne, who stays in a particular stage but persists, that isn't improving and therefore requires a revision of what is actually the care model. And for Simon, who was already in stage 2 but develops a more complex illness within that stage, what are the next processes in terms of treatment? Next slide.
We first met 17-year-old Jane when she presented to her local Headspace service at the request of her parents who were worried about her increasing anxiety in the lead up to her final school exams. Her parents were worried about some disturbed eating behaviors they observed, such as binging and recurrent eating. When Jane made her appointment with Headspace, she was asked to complete questions about herself before her appointment via the Inawell platform. When she had completed her questionnaires, Jane was able to see in real time her dashboard to comprehensively give her a holistic view of how she was tracking across multiple health domains. Her dashboard showed some concerns for social connectedness, anxiety, sleep-wake cycle, eating behaviors and body image, psychological distress, and social and occupational function. When she presented to her first in-clinic appointment at Headspace, Jane appeared to be of healthy weight and neatly dressed in her school uniform. Though she appeared nervous, she expressed normal cognitive functioning and reported how since the beginning of year 10, she has been isolating herself more and more, turning down invitations with her friends to hang out, and often ignoring her mobile phone.
So, as we move to the particular team review in this particular issue about Jane's actual progress, the important thing here was that those who are tracking her ongoing care, the digital navigator, noticed marked deterioration since her last check-in via Visio visit. So this is an example where using, in fact, technology alerts us to a change in the situation. In the original situation where this was noticed that she dropped out of school and she was not going to sit her final exams, not surprising for someone who's often very anxious, she seemed relieved and less anxious and suggested that she'd be looking for a job in retail to make ends meet and keep her parents happy. However, at 2 months, it's noted that Jane's yet to find a job. Her parents are now more distressed about her decision to leave school and causing tension at home. She'd become more depressed, had lost contact with her school friends, stopped playing sports on weekends, and along with a low mood, describes daytime fatigue, oversleeping, persistent lack of interest in daytime activities. In addition, her previous disturbed eating behaviours have worsened with periods of binging and purging more frequent. She also describes punching her own legs when taking a shower. On mental state examination, she appears to have gained weight, she's more unkempt, and she's poorly dressed. You may remember earlier on, she'd been in a school uniform and neatly presented and cognitively interactive. She's also more preoccupied and sad about her body shape, as well as perceiving to be more rejected by her friends and family. So a general deterioration in her presentation and in her level of functioning since her original assessment. Next slide. If we look at that in terms of the current dashboard as reporting, you can see changes in terms of, particularly right now, her poor everyday functioning, her poor level of social connectedness, not an increase in risks around suicidality, but generally a deterioration in her mental health overall. Next slide. One of the important issues here for us is actually tracking. So looking over the 3-month period, while we had hoped to keep her connected, finishing with school, staying engaged with the school processes, what we actually see is actually deterioration in her overall health, mental health. Here is indicated by upswings in the graphs over time, poor levels of social connectedness persisting, some increase in the suicidal thoughts and behaviour from a low baseline, and generally a decline in everyday functioning. So the situation here is across the key domains from our multidimensional assessment point of view, a general deterioration in those key domains, and of concern that our original model for care hasn't progressed in the way that we would have hoped. Next slide. So in terms of service provision, from clinical stage point of view, she's progressed from stage 1A to 1B with more obvious depressive symptoms, worsening functioning, worsening occupational engagement and social connection on an ongoing basis. There are a lot of factors which can influence social and occupational functioning, as shown on the top right, but there are a lot of things that we can actually look at in terms of further assessment. So this is the point of case review. What's to be done next? Liz, pretty commonly we see people where we set out with the best of intentions to have them engage with school. It doesn't go well. They don't finish exams. They're stuck at home, become more isolated, more depressed. When you look at the range of options and the general progression here of the things that we might be discussing next, what would be top of your list for next consideration?
I mean, I guess one of the things to point out, she's still engaged in care, and that often at this point we see people drop out of care. So the fact that actually this young person has continued in a system, and that we can pick that up, that there has been a deterioration, is obviously of incredibly important. And this is the point.
So we still got a hold on her.
We still got a hold of her, right? Exactly. She hasn't.
Or at least someone's bringing her back.
That's right. Exactly. Exactly. So from a service point of view, we'd obviously done enough to engage her or engage her family, or to indicate that we are interested in continuing to provide care and support for her, as she is navigating just from school to the community. So, and into work. So I think the important things at this stage is about that. What does further assessment indicate? Really important, obviously, to find out what her preferences are and what her model of her problems are, and how her family fit into that network, particularly when you're talking about disordered eating. And engaging family members in a shared plan is really important. So critical to involve families, critical to find out the young person's perspective, understand a bit about what their psychological framework is, how they might respond to different types of therapy, and really what is the problems that they want to engage with, that they identify, so that we can make a collaborative care plan with them.
So we had a pretty light touch originally of monitoring options in terms of care, trying to encourage the completion of the school situation, but we didn't succeed. So of the options in terms of either, firstly, more specific psychological therapies, of the options that are available, where would you be going in terms of actually pushing really into more overt psychological therapy as distinct from more self-directed therapies or more general support?
So I'd certainly be looking for individual CBT for her, and with a focus around her, so some of those things indicative of risk. So about her emotional regulation, her risk, impulsivity and safety, looking at issues around self-esteem and body image, and her disordered eating. So really prioritizing the individual CBT, finding a psychologist and a psychological therapy that would be suitable for her.
Pretty much assuming that anxiety is driving it.
Pretty much assuming that anxiety, low self-esteem is driving a lot of and particularly issues around kind of body image, probably perfectionism, that are driving some of the difficulties that she has.
Personally, I've got to say, for someone who's becoming less active, more at home, gaining weight, more fatigued, more disconnected, the issue around behavioural activation, for me, increasing her activity, pushing mood, seeing the extent to which actually increased activity, particularly physical activity, might lead to improved mood and overall functioning, in turn controlling her body weight, would also be fairly high on my list of kind of priorities. So getting the psychological therapy right, perhaps with also emphasis on the behavioural activities that may match, depending on, of course, as you raised, her preference. What about the other issue? We let her go and she didn't do the school exams. What's to be retrieved now?
Absolutely never give up on school and maintaining people in an educational framework. So I'll be looking to see whether it is possible. What are the educational options for her to come up with an educational plan? And that does require a bit of understanding of the school system and how to support her back into education, whether that's in school or in TAFE. What are the barriers for her? Has it been fatigue and poor concentration, not being able to get up, not being able to get out of bed, not being able to keep up with her tasks, so a reduced study load or different pathways in terms of options in education, and if not, supported into alternative activities that will enable her to improve her function so that she can go back to education or go back to work. But obviously,
she's gone down a bad path here, though. We've let her. It has been the case that anxiety has resulted in avoidance.
Yep.
And she's avoided the school exams, which of course she was greatly relieved her anxiety.
Yep.
So we've tapped into, in fact,
avoidance. Yes.
So, the other side of the coin here, and worse, of course, if another 6 months or a whole 12 months goes by and she doesn't actually engage further in education. Mm-hmm. So one of the things about school years and other opportunities, often we lose an opportunity at the end of a school year and there's off for a whole other year again. So the emphasis on actually finding another pathway to progress her school and if potentially post-school kind of pathway, fairly critical at this point. Otherwise we end up with people 12 months, 24 months down the track who haven't done anything.
Yep.
And still haven't graduated school.
No, and whose mood is worse. And also the scaffolding of school in terms of getting up in the morning and having, exposure to light and activity and the brain stimulation associated with that are all critical at this age and stage.
Right. So social connectedness in this particular situation may well depend on educational participation in one form or another. back at the school where she was, in school, in some other alternative pathway
Yep.
for a particular thing. It'd be pretty high. There's a mention a lot of increasing tension and, not surprisingly, parents who are pretty distressed in this particular kind of point.
Mm.
So engagement of parents at this particular issue in agreeing the educational options, agreeing the psychological options, perhaps in contributing to the behavioural activation and doing things together, all might be particularly relevant in our area. What about when somebody says, should she take a medication? Should she take an SSRI? Should she now? And, you know, frequently we would inherit such people from a general practitioner or somebody else who may say, is it time that she took a medication at this point? What's your threshold for saying, actually, this is or isn't the right point to be thinking about medication, particularly an SSRI for an anxiety-driven depression at this point?
I think that a lot of that depends on severity and on their kind of other factors. How long has the condition been going on for? Have they had an adequate trial of therapy but failed to respond? Other issues associated with risk? Is this a critical point at which, if they recovered quickly and got back to school, then we could salvage their kind of educational status? So I think all of those things, what is their personal preference? What are their family's views about that? What are the genetics of their family's experience? If they've had other family members who've had depression or treated with antidepressants, what have their responses to that been? Always bearing in mind that in a young person who may have some atypical depressive symptoms, change in energy and change in sleep, that antidepressants, if somebody falls within a bipolar spectrum, may cause agitation, activation, and then an increase in risk. So all of these things have to be considered very carefully.
But in this particular situation, we don't have a lot of evidence of those other risk factors.
No.
And it would seem that she probably has not, up to this point, had really good individual psychological therapy. So I think we'd be really saying, let's really go the psychological therapy,
Absolutely.
the behaviour activation, the engagement with schools.
Yes.
But if she doesn't respond, if things go badly, if the depression continues to worsen, then the issue of potentially SSRI might be an issue that arises further down the track. So I think one of the issues is that there are options. I think it's true in services that we're associated with, where there's a strong emphasis on good CBT, proper behavioural activation, concurrent emphasis on education and vocational support. We're not in a hurry to prescribe, simply reserving it as one of the issues that may well be relevant down the track, as you say, depending on the level of anxiety and the level of actual disturbance.
Yes.
And then potentially close supervision if that were to happen. So we would, I think at that point, say, look, there are a range of other intensity of operations. We went for a fairly low intensity operation or intervention in the first instance. Now she's a stage 1B. We're moving along the intensity of services, as you can see on the left. We're stepping up what we do relevant to the deterioration in her stage and her function, with an increased need to then supervise and watch what happens, with a range of other possible options to consider if things do not go well. Having deteriorated in the first instance, despite our best wishes, from stage A to 1B, now we would have an increased emphasis on close tracking, that the situation does not further deteriorate, or that she does not stay and become entrenched in this pattern of avoidance, of being at home, of failure to progress from an education and vocational support, and becoming more socially isolated, and the risks associated with that. Okay, next slide.
Anne is a 22-year-old student at the University of Sydney who is in her third year of studies. She presented to the university's student counseling services at the request of one of her tutors, who has noticed a stark change in Anne's performance in school. Anne has also noticeably become withdrawn from social activities despite living with her friends in a share house. Before Anne's first appointment with the counselor, she was asked to complete the questionnaires on the InnoWell platform. Her real-time health dashboard indicated concerns across various health domains such as alcohol use, suicidal thoughts and behaviors, social connectedness, self-harm, sleep-wake cycle, and depressed mood. At her initial in-clinic appointment with the university's counselor, Anne presented with low mood and kept reverting back to her ugly Eurasian appearance. Anne is of mixed European and Asian heritage and has expressed increasing paranoia that her friends think she is ugly. She was treated for a major depressive episode at 18 years old and has a prior 2-year history of social anxiety and panic attacks.
So, at our team review for this situation, unfortunately, Anne had progressed to actually making a serious suicide attempt. So initially we had assessed her as stage 1B. We had developed a shared care plan, including a suicide safety plan, some online absentee tools, as well as psychological therapies for her depression, anxiety, and psychosis-like experiences. It was agreed that the counsellor would predominantly use video visits and to supplement with clinical visits. She participated for approximately 3 months in CBT, but her mood deteriorated, her paranoia worsened, and she stopped attending all sessions as she refused to talk with people during daylight hours. With intention to make it all go away, she took an overdose of painkillers mixed with alcohol. Fortunately, her housemates called an ambulance and she was admitted to hospital. Discharged, mental health acute care team nurse contacted the treating counsellor, immediately set up a video visit to see Anne that same day. During this video visit, Anne said she was convinced her housemates were conspiring to harm her, that other people in the street could tell from her erasing experience that she was bad. Her mother also attended the video visit and explained that Anne had withdrawn from university and was now moving back home. Mum also noted how Anne believed she shouldn't trust anyone who isn't family. Anne further described a sense of being cognitively damaged and unable to function properly, given she's a university student, very importantly, and she was hearing people comment on her every move from the moment she woke up. This led to her drinking even more heavily to dull her thoughts. On mental state examination, she'd only been seen in the presence of her mother and was clearly distracted during the interview. She was agitated, hypervigilant, and really didn't want to be in the session. She was coherent, but her answers were short and there were not much elaboration, not easy to engage with, particularly through the video process. Next slide. So her most recent multidimensional assessments are all pretty significantly impaired. Lots of red on our particular dashboard meters, particularly about ongoing suicidal thoughts of behaviour and certainly having made a serious suicide attempt, cause for great concern. So her being more and more disconnected and really only being in contact with her family, and her everyday function was poor, particularly given that she had been a functioning university student. The next slide. So what we see over the 3-month period, these worsenings in the situation where she was already doing poorly, and despite the plans that had been sent up in these particular situations, not doing well. You'll also note in the top right-hand corner that the increasing input by Anne's mother, who's now also contributing data to her dashboard. So particularly a situation where you want to see what somebody else, in this case, Anne's mum, is actually reporting. And consistent with Anne's own reports, generally speaking, it's a deterioration in function. So strong corroboration of the seriousness of the situation by Anne's mum. Next slide. So what we see in this particular situation is that Anne has clearly progressed from the stage 1B initially that we had seen through to the border of stage 1B to stage 2. And although there would be some debate at this point of whether she's clearly developed a psychotic disorder, we don't have clear evidence of that. Clearly, the suicide attempt, the worsening function, and the seriousness of the situation means in terms of the intensity of the services that we would provide, that we certainly need to move to more intensive services and close monitoring of the situation. When we get into what's to be done next, Liz, at this point, clearly there's issues of needing to connect with her. She's retreated home into her mother's care. So clearly the issue for us of us going out to make sure. You made the point with the earlier one of someone staying in contact with services. This is someone who wants to withdraw from services, has already taken one serious overdose, is more disconnected. So how easily is it to get services to chase someone like Anne, to engage?
So Anne at this point presumably has not got into a first episode psychosis team. So dealing with Anne in the community, it's very hard to have assertive case management, ambulatory care, home-based care. It's a major deficit in our service system. So actually going out and seeing young people like this in their home to try and re-engage them in care is incredibly important and extremely
So if we
difficult to
could,
do.
I mean, if you're in one of those areas where there is an assertive outreach, or you just raised the issue of either an early psychosis team or an at-risk to psychosis team, because she's clearly in the least at-risk. Like we would say she's stage 1B, maybe stage 2, at least in the at-risk kind of concept. She's clearly in the at-risk category, the paranoid ideation, and she's at risk. So if there was such a service, you'd use that. Interesting, in this particular scenario, we're talking about using video visits. We have not exactly got in the home, but at least we're still in contact with the mother and her. And I think it's one of the interesting issues about technology. Actually, we were attempting to provide ongoing care at home, but the issue is here we're probably dependent now more on mum to actually facilitate this. So one way or another, the management has to be more assertive. Can't afford to lose contact with her now. And we don't know where she's going in terms of whether she may progress to a full psychotic syndrome or that she's just in a really risky state, which she may be in, certainly for the next 12 months, certainly for the next 2 years, to be very careful about potential progression. In terms of the psychological therapy kind of options, I mean, there's a lot of debate about continuing, not debate, emphasis really on continuing to use psychological therapies, even when people have psychosis-like experiences, the extent to which they may be driven by anxiety, they still may respond to psychological care. But you'd want to have someone who knew what they were doing.
You would.
So experienced psychologist,
yes,
experienced person in this particular area.
Yeah, who can actually monitor and track that and understand the significance of the psychotic type experiences and make sure that they are, you know, kind of appropriately assessed. But obviously her degree of withdrawal from family and from the community is a major concern.
So this one with the body image issues, you know, someone who's the Eurasian experience thinks that people are looking at them. Now there's the sense that people are talking about them in particular areas. I mean, the sophistication of an appropriate clinical psychologist or other in this area clearly matters in terms of not misunderstanding or picking up the extent to which that has more psychotic-like phenomena. As distinct from social anxiety or sensitivity about body appearance.
Absolutely.
A common phenomena.
A common phenomena. So it does require the expertise to be able to distinguish between social anxiety, and particularly a young person with a very high level of arousal, and what is the development of a more progressive kind of psychotic illness.
So up to this point, she hasn't seen a psychiatrist necessarily. Hopefully she has been seen by a clinical psychologist with some sufficient skill or a mental health nurse with some skill. But clearly there is a point here at the moment of a need to engage somebody from a pattern recognition point of view who could sort out how close she is to transitioning to a psychotic illness or the psychotic intensity, psychotic-like intensity of these particular kind of sets of issues. So I guess we have the experience often when people at this stage actually don't get escalated easily because of a lack of access. But this seems that point at which you've got to get someone involved to track this particular phenomena. Even if they can't sort out right now, clearly or not, whether this is a psychosis or not.
Yes, and at this point to be able to determine whether the level of whether the psychological therapy or the treatment they've received has really kind of addressed the syndrome that they have. Is it just, you know, continuing ongoing anxiety, which she hasn't really engaged in treatment, or the treatment really hasn't been targeting the appropriate kind of areas? Is she treatment non-responsive for some particular reason, or is this really a progression? So it needs somebody who can actually determine those factors and determine what are the next steps in care in collaboration with her clinical team and with her and her family. Okay, so when you've got that involved, the other reason from a psychiatrist's point of view is, okay, there's a temptation at this point, strong temptation to get out the script pad or the electronic prescribing device in this case. What do you think? What do you think is the threshold here for making decisions about, okay, when, how, what in terms of medications? So I think threshold means taking into account that multi-dimensional assessment that we've talked about and looking at all the factors that may be contributing to high levels of anxiety arousal, or that may be contributing to her irrational or potentially delusional thinking. And those include issues around sleep, around drug and alcohol use, around physical activity and social contact and social connectedness. So it means taking those things into account, looking at the level of risk, looking at the level of engagement with treatment, what are the factors that are likely to be involved in compliance. Then really the difficult decision often of weighing up of when to start a medication and whether that medication, what that medication should be, whether it should be targeting anxiety or targeting sleep, or whether it should actually be the initiation of an antipsychotic medication.
So if you thought in this situation after assessment that it's anxiety driven, in terms of the pathophysiology here, it's more an anxiety driven sort of phenomenon, where would you be going medication wise?
I'd start with first line treatment would be generally with an SSRI.
And if you thought in a sense it's more than that, so you've really got in mind that she's very perturbed, she's already attempted suicide, she already has a degree of agitation, she already has a degree of certainly paranoid ideation and super sensitivity about other kind of factors. At what point would you be thinking an antipsychotic may actually be a relevant intervention?
So again, that's based on risk and also on level of function, her capacity to actually engage in ongoing treatment and monitoring. So if it really looks as though the deterioration has been such that she is on that, as you say, on that threshold, crossing into a kind of full threshold psychotic disorder, then I think choosing an antipsychotic medication, thinking about the symptoms that she has and trying to choose medications, obviously, that we know have a degree of evidence in terms of young people, those that are metabolically the better in terms of particularly young women and young women around body image, thinking about the side effect profiles and thinking about kind of long-term engagement in care. So I think I would be strongly driven in this case to think about antipsychotic medication.
Now, of course, we're sort of expressing our usual reservation about starting medication, but she's self-medicating. She's gone down the alcohol track. She's mixed alcohol and painkillers in terms of the suicide attempt. There's the difficult issue here. When we don't act, she has acted in a particular issue. So I think there's often this negotiation about, your drugs, my drugs, what's going to happen next. Can we provide better options in trying to either control her anxiety, dealing with her sleep disturbance, dealing with her distress in particular sets of ways. So in terms of the negotiation with her, and you've raised another one, which is, of course, if you go for one of the medications, it's highly likely to result in a young woman like this that gains weight. That's not going to be a great option as we go. On the other hand, the sedative properties of some antipsychotics or of some other agents in terms of storing sleep-wake cycles may actually be particularly kind of pertinent. So I suggest at this stage, with her and her mum, and it may involve a mental health nurse or it may involve others, issues around metabolic assessment, issues about particular options. But clearly she's in that situation where even if you're not necessarily saying that she's got an established psychosis, there's certainly, if you can go for the anxiety control and the sleep control, there are issues about whether using one of our medications rather than her self-medicating is a better option to try and get the situation back under control. But if so, it's going to need to be closely monitored, going to need to be looked at. How's it going to happen if you haven't got an assertive case management? Clearly, we don't want to chuck medication in of ours on top of her alcohol and painkillers. We don't want to take in an overdose of our medication and her medication in the particular kinds of issues. She does raise the issue about cognitive decline, and there is the issue in a lot of our work at the moment about introducing formal neuropsychological assessment as to what is the nature of her cognitive difficulties at this point. Do you want to comment about that?
We don't use it anywhere near as much as we should. We don't use it as part of our standard kind of clinical battery of tests, even though we know that people present with problems with concentration, short-term memory, and those are major factors in their difficulties in engaging in school, in work, or in social participation. So, and neuropsychological assessment is something that we've been trying to bring into routine clinical practice. These tests are available online at low cost that give us and can be monitored and tracked over time. And I think that's really important in these situations. It does give us an idea about the level of severity of the syndrome that she has, but it's also something that we can track over time. If our treatments improve symptoms or they improve anxiety, but they're not improving cognitive function, which is one of the major indicators of function in the world, in the community, then we're really not doing our job, and we really have not got things under control. So I think it's extremely important.
It's also interesting to see the pattern, isn't it? I mean, whether there's a general decrement, whether actually given her university status, she's really functioning across the board on very poor level, including executive function, more complex cognitive tasks.
Yes.
Or whether it's more what you see in anxiety, etc. There may be action, there may be actual concentration issues, but other functions are largely intact. Certainly when considering whether she has a psychotic disorder, there's more widespread disruption, or there are other particular aspects that are relevant. Of course, also where she simply is at relative to where she has been for a university student gives you some idea of the decrement in function over time. So certainly that's one of the other areas to be looking at, as well as the issues that you alluded to. Clearly in this particular situation, the wider physical assessment, the wider metabolic assessment that we've emphasised in previous seminars comes into play. One way or another, Anne is headed into a very difficult period. It's already a difficult period, it's already deteriorated. She may, and is at high risk, obviously, of progressing to a stage 2, to a full-blown disorder from a disorder point of view. Perhaps more importantly, from a functioning point of view, she's already deteriorated. Her risk is already significant. She's already attempted suicide, and the level of service intensity and multidimensional nature of that service. So we look at the neuropsychology, we talk about the emphasis on really good CBT. I think we've raised the issue that in our work, we would particularly be looking for mental health nurses and those who might be involved in assertive case management to engage, and certainly supporting her mother in this situation.
And education, vocational support down the track.
So having dropped out of university, she's more disconnected. So how are we going to try and establish what particularly happens? Probably going to need to get the syndrome under a degree of control fairly quickly, and actually being less anxious about actual other social interactions if that's possible. From a service point of view, or from an individual care model point of view, this is exactly the sort of situation where we'd be suggesting there's got to be at least 12 months of complex following, assertive management, tracking to get out of the situation. Decisions will need to be made by a comprehensive multidisciplinary team. This is exactly the situation where we don't think just more sessions with one individual person, whoever that may be, psychologically wise, nurse wise, psychiatrist wise, is going to be enough. There are a lot of issues in play in this kind of case. And the difficulty without a framework of trying to stay in contact with her, just relying on her or her mum to bring it back to her, is that we lose contact. We've already seen the risks of that in the first instance with the suicide attempt between the initial presentation for care and the current situation. So this is one of those situations where in a laissez-faire system, we would lose contact with Anne, and we may well run the risk that she does not survive, or that she continues to deteriorate and becomes actually much, much more impaired in a particular function. So the work that we've been associated with this kind of deterioration, even though it's evident, is often not sufficiently tracked until it becomes much worse and demands actually further care. The attempt to make a real difference here is critical in the lives of people like Anne. Next slide.
Simon, or Cy, is a 19-year-old who presented to his local Aboriginal health service in Queensland with symptoms of severe depression. He is currently unable to get out of bed for days at a time, has insomnia, and turns to binge drinking and marijuana to pass the time during the night. He has also recently lost his job as a result of the COVID-19 pandemic and is not engaged with any other studies. In an effort to turn his life around for the better, for the sake of his 1-year-old son and girlfriend, Cy is seeking help and has completed his online questionnaires on the InnoWell platform, which indicated concerns across the majority of his health domains. At his initial appointment, Cy appeared to slump in his chair and avoided all eye contact with his health practitioner. He also spoke very slowly and had minimal reaction to any social or emotional cues. Cy reported a history of depressive symptoms throughout adolescence, including mood swings, and shared his experience of previously being prescribed an SSRI alongside 10 sessions of cognitive behavioral therapy with a psychologist.
Okay, so when Cy originally presented, a young Aboriginal man through his health services, it was clear diagnosis of a major depressive episode, lots of other surrounding psychological difficulties, an attempt to then be very assertive in his care and social engagement. This far down the track, however, something else unpredicted, not entirely unpredictable, but something unpredicted happened. He developed a clear hypomanic episode. So now he's presenting, coming back into our service, having clearly progressed. He was originally actually assigned stage 2 as a provisional diagnosis on the basis of his severe depressive episode, and had an original suicide safety plan, and we were tracking what would happen, with also an emphasis on providing appropriate support services. There was a strong emphasis on trying to keep him engaged with in-clinic visits, not just video type visits, and trying to use video visits to back that up to monitor his progress. So originally at 3 months, there was no change in his mood. After a wider consultation with his kinship group, he was prescribed an antidepressant to which he appeared to have a reasonable symptomatic response without particular side effects. And attempts were made to arrange casual work at his uncle's business, and with the idea that he may actually progress to an electrician apprenticeship. However, he was increasingly distracted, needed regular breaks, asking for afternoon naps. Things didn't progress that well. When he was seen then at 6 months with his girlfriend, he excitedly stated he'd never felt better. He was happy, energetic, creative. His girlfriend described he'd become ridiculously active in the past couple of weeks. He'd been engaging in protest organisations, frantically writing and preparing screenplays, leaving the house very early in the morning, home in the middle of the night, without spending any meaningful time with his family. Not turning up to work, boasted about his achievements with Black Lives Matter movements and how global process depended on him. On mental state examination at that point, he was very clearly agitated and talkative, frequently interrupted his girlfriend and health professionals, and clearly unable to sit still or, from a motor point of view, stay at all calm. So there was clear evidence that he had developed a significant, at least hypomanic, and on danger of being flagrantly manic, having been treated with antidepressant for his depressive episode. Next slide. Now, because Sai was filling in the questionnaires himself, he said, everything's fine. So the dangers of self-report is self-report can't tell you everything. And in fact, in this situation, if you've gone from being really miserable and feeling really terrible, as Sai had, to now feeling on top of the world that he could do anything and was actually out being, as far as he was concerned, extremely productive and connected with the world, not surprising that his self-assessment said everything's fine. Next slide. If you look at right across the InnerWell platform, though, into other areas of functioning, including the possibility of mania-like experiences and sleep-wake cycle phenomena, clearly there were other issues that were running that no longer focused on depressed mood and inactivity and disconnection, but it indicated problematic areas for further examination. Next slide. Now again, here we can see the reporting by an important other, in this case, Sai's girlfriend in blue. So while he's reporting everything's going fine, of course, she is reporting in the blue, everything's not going fine. This is where using such systems, not just by reporting, but can be really helpful to actually say, in many situations, and certainly as illnesses often progress, the engagement of a critical other in that process. Now, this is not just a matter of getting the information from that critical other. It's an issue of forming partnerships with critical others to say we rely on the reporting of family and close kin often to actually tell us what is happening and for us to respond in those situations. So even though a person says, I'm fine, if those closest say, well, clearly he's not fine, they are also empowered to actually enter into the treatment relationship. Next slide. So in this situation, Si was already a provisional stage 2 on the severity of his depression. At the 6-month follow-up, where he's clearly developed a hypomanic stroke manic episode, he's in danger of being hospitalised shortly if this continues. There has been progression within that stage, and obviously at this point, the intensity of services really needs to be stepped up. Now that's going to include some pretty significant decisions about whether hospitalisation is part of that, or whether, in fact, this level of disturbance can be managed actually on an outpatient basis in the particular situation, and the issues related to the introduction of appropriate medication for this hypomanic episode comes into play. So Liz, young Aboriginal man like this, family and kin, many kind of issues. Where's your feeling about, you know, the point at which hospitalisation becomes an appropriate strategy versus can potentially the situation be managed on an outpatient basis with appropriate medication?
So I think always, I mean, for everybody, but particularly for young people, trying to manage people at home within their community, within their kind of, for him, within his kinship group is actually incredibly important. And often people's first experience of hospitalisation, as we know, can be incredibly traumatic, particularly if it involves the Mental Health Act and involuntary treatment. So it does require urgent, assertive treatment, working with family, making sure that his son is kind of safe, obviously, and, you know, cared for, but trying to work with him and work with his social network to make sure that he gets the assertive treatment that he needs to get his symptoms under control to prevent further deterioration or crisis, and hospitalisation would be my goal.
So the issue about what's traumatic is often a really important kind of question, because if you wait too late,
yep,
and you end up with police and family disruption and potential conflict, including physical conflict within a home environment, and crew goes, not only is it traumatic for him, it's very traumatic for family. On the other hand, hospitalisation for a particular issue away from your kinship group, and obviously in this particular situation, particularly important that the kinship group and its own experiences with custodial systems may be very relevant to that kind of consideration. So depending on the services that are available, when you're associated yourself with inpatient services for young people that actually admit people earlier in non-traumatic situations to try and avoid the trauma later by offering different styles of care. Do you want to comment on that? Because that issue about hospitalisation as a last resort, but in circumstances which are often very traumatic,
yes,
there is the issue about whether that could have been avoided,
yes,
in other ways, or at least in some settings.
yes. So, I mean, our goal would be ultimately to have more hospital in the home type care, and that's obviously a goal for all services. It's true in the public sector, it's also true in the private sector, looking at how we move forward in terms of provision of care. But at the moment, the private system that I run, or the unit that we run, which is for young people with mental health disorders like the one that Si has, really aims to provide intervention to prevent further deterioration and further harm or further risk. So actually, if you can engage people, and not easy when people are hypomanic to actually convince people about the need for care, but families often can. And with support for families, actually getting people into hospital early, particularly managing their sleep. So in these situations, if you can actually stabilize people's sleep using medication, but also the structure of hospital and the behavioral kind of strategies around reduction in stimuli and providing kind of supportive environments to kind of stabilize people's sleep-wake cycle and routine, that can be incredibly helpful in the early, reducing symptoms earlier and preventing further harm.
So the issue of, particularly in the COVID-19 world, of trying to do things away from institutions,
Sure.
so doing things in the home, I guess the hospital in the home thing, if it's real,
yes.
I mean, the issue here of supporting a family where you're going to have to start medication, particular issue, probably inevitable in this situation, so what set of antipsychotics that consists of and what sedative properties they have in terms of trying to restore a sleep-wake cycle, whether shortly down the track lithium becomes an option, or certainly a mood stabiliser becomes an option, and its management with the appropriate care and the appropriate monitoring, you're really talking about a sophisticated multidisciplinary team with a medical backup, often mental health nursing, assertive support of the family, or whoever our key care providers here. Close daily monitoring of the situation becomes critical. I mean, it is obviously the case in many of our service systems. That doesn't really happen, and families are left a lot on their own in situations. So while families often choose, and most of us would choose, to be treated at home and not be hospitalised, there is this real tension. If you're going down that route, you need to make sure everyone's on board, and that it's really going to happen in an appropriate way, and that we are set up to respond to that, and the hospitalisation. So I think the issue here, for me anyway, is that trauma is avoided. Unfortunately, we now associate acute hospitalisation and certainly voluntary hospitalisation with a great deal of trauma, and we haven't necessarily worked on actually reducing that. But we can give rise to other problems for not only Sai himself, but his family if we fail to respond and actually work with a family in a particular setting that he's in, which would of course be optimal if that's possible. So the way in which multidisciplinary teams really work in these particular situations, or really do respond to this deterioration, is a challenge, I think, for all of us. In addition to the obvious medical issues that arise, the safety issues, the avoidance of trauma that we talked about, clearly education for the family once this young man has had a hypomanic episode. So his vulnerability to a bipolar type disorder has been revealed now, whether it was a consequence of the antidepressant prescribing, whether it's what would have happened anyway in that particular issues, just in terms of providing information to the family and then emphasising the return to social rhythms, not just social rhythms, but circadian rhythms to actually the management of these situations. Do you want to make a sort of comment about that? Because that's often big news to a family.
Yes. And I mean, my experience is families and individuals are incredibly relieved to actually have an explanatory model and understand a bit about brain function, to have a model that explains how their sleep is managed, about brain clock systems, because it also is a model that explains one of the things that you can do to self-manage. So it explains the importance of sleep and activity patterns, of avoiding drugs and alcohol, of thinking about reducing stimuli in times when people's mood is elevated or they're activated, increasing stimuli using behavioural activation when their mood is low. So it really gives families an idea and individuals about what they can do to self-manage and manage their illness, and what the role of the different medications are and why we choose certain things, and how important it is in terms of the other treatments that people have around sleep, activity patterns, social scaffolding, and around the kind of management of comorbidity like drug and alcohol use.
I suppose a number of things to say unapologetically in this situation. We're advocates of lithium therapy as a preventive therapy for recurrence of mania in particular situations at an appropriate time and place. But the circadian kind of idea, the pathophysiological pathway, but unstable 24-hour sleep activity rhythms. Because it's not only how do you medicate or regulate the sleep in this acute phase and restoring sleep-wake cycles, not making him asleep all the time, restoring sleep-wake cycles is a critical element, but also the issue that's alluded to here is also about the longer-term work and support. One of the ways, particularly for young men, to end up back in regular cycles is to be in regular work. I think when these things happen, people often worry, oh my God, he won't go back to work, he won't be able to resume normal function, and become very protective at one level. But actually, the restoration of regular rhythms of activity is often critical. So he didn't progress with business, with his apprenticeship, with potentially working with his uncle's business, etc. So this issue about the extent to which, despite the severity of the episode, one can start to look at what are going to be the longer term regulators of actual function is a critical consideration. So at this point, I think often families are terrified,
Yes.
really worried about what happens. In terms of his prognosis at this kind of situation, what are you going to say? What are you going to say about his future and about the particular kind of vulnerability that's been revealed?
I think it is about managing risk and the risk of further episodes, and about the need to engage in the kind of longer term care and monitoring, and to make sure that the relevant systems are in place.
So we'd be saying at the service level, everyone's going to get serious for at least the next 2 years.
Yep.
And probably beyond that. And given the family situations here and the responsibilities here, this vulnerability having been revealed. That vulnerability isn't lifetime illness. It sure means that in certain situations where his sleep-wake cycle may be disrupted, there's issues maybe in relation to medication, because he has had a severe depressive episode and he may lapse back into a severe depressive episode. The issue of mood stabilizers, lithium being the preferred agent, the issue about restoration of things. And so the education, I often hate the word psychoeducation as if it's some pamphlet's going to be handed over. There, go read about that or just find out about it. As distinct from really a much deeper appreciation of the way in which body clocks, circadian systems are actually primed by experience, they're upset by seasons, they can happen a variety of other trigger factors that may disturb them, but also the extent to which they may be regulated by the activity, not just of Sai himself, but by his family and how they actually adapt and how they may actually support him on an ongoing basis.
Yeah, and also how drugs like lithium work. I think it's really helpful in terms of adherence for people to understand about why certain drugs may, how they fit into that kind of model and why they're so important.
Okay, so some pretty challenging times ahead for Sai and his family. So in summary, what we've been looking at tonight is how you look at cases where things didn't really go the way that we might have hoped. And we've been using health information technologies to actually track people over time, to actually look at how multidisciplinary team review can take place, how routine outcome monitoring can contribute, how there's a need to look at not only what is happening in terms of clinical stage, but in terms of progression of illness is happening, and how a multidisciplinary team can get involved in a dialogue about treatment options, increasing specialisation, increasing intensity of treatment on an ongoing basis, and the way in which not just more of the same, but different combinations need to come into play. Hopefully, we've given a sense about partnerships with young people and their families, providing options, talking about what can be done. Of course, needing to look in a relevant way at what service models are available for promoting safety, but also promoting best long-term care. These are very challenging situations with young people, and trying to get the care options right as quickly as possible, particularly in the face of persisting illness or deteriorating situations, and not just waiting for things to get really bad, has been emphasised. We'll continue to provide further training, and Liz in particular will be providing further supervision of individual cases through our particular systems. This kind of work would not be possible without the support of a range of our partners, and that's particularly a number of families who have really supported our work on these particular brain and mind models for young people, particularly also the financial support of Future Generation Global in developing these seminars and the technologies in search of the partnerships for these particular areas. We look forward to further examples of, believe it or not, even more complex cases in the future where even more extensive treatment options really need to be considered for those young people who progress to much more complex presentations than the ones we've shown this evening. Hope to see you on our next seminar.